The leading cause of death among neonates or in the NICU is going to be prematurity. And prematurity is going to pose very many effects on the physiology of the infant. Think about the human being, but everything immature. This means there is a lot of system failures, and without the proper support, this child or this neonate is not going to make it. So this makes it something that is going to be always tested on examination. The different diseases that are specific to neonates that are preterm are going to be a favorite. And when it comes to management on the ward, it's going to be hell. You're going to monitor everything. Fluids are going to be very strict and everything like that. Now, if you're new to this channel, this is made one pager. We try and get a high yield topic, summarize it on a single page, and then try to discuss it fully in detail, at least for most of the high yield part. Now, in the description of this video, I'm going to drop there a message. I'm going to put there a criteria that is very important for you to know, and that is the Ballard score. This is the score that is going to help you as a physician understand the difference between a preterm and a small for gestational age child. And this is something that I'm going to explain further in this video, and you're going to see why it is very critical for you to understand. So prematurity or preterm birth is going to be the birth before 37 completed weeks of gestation. So we take it that we expect a child to be born at 40 weeks. But anything before 37 weeks, we are going to consider that a preterm. And anything above 37 weeks, we are going to consider that a term baby. So we have different classifications, and these are important because not only do they classify or help you know what you're dealing with, but they most of the time also stress the severity of the prematurity and the different severity of the problems that you're most likely to fail. So we have the classification by gestation age, and this is going to be divided into the extremely preterm. That is anything that is below 28 weeks of gestation, the very preterm, the moderate preterm, and then the late preterm. The very preterm infant is going to be more than 28 weeks but less than 31. And when you enter the territory of 32 to 33, you are in moderate preterm. And then the late preterm is the baby at 34 weeks to 36 weeks and 6 days. Then we have another classification that is very, very important, and that is the classification by weight. And what makes this important is the mortality association with the extremely low birth weight infant, the ELBW. For infants less than 1,000 grams, even in developed countries, the mortality is as high as 71%. And this is going to be something that we're going to heavily look at in this video. When you look at the risk factors, we have the maternal risk factors, the fetal risk factors, and then we have the iatrogenic causes of prematurity or preterm birth. The maternal causes are going to be most of the time infection. Whenever a mother has infection, there's no way that pregnancy is going to remain. We are going to expedite their delivery. We are going to make sure they deliver very fast. That is chorioamnionitis. Then we have things like hypertension in pregnancy, preeclampsia, eclampsia, and things like that. PROM, which is the premature rupture of membranes or preterm rupture of membranes. And this is going to be something that is also very important, because once the membranes rupture, then the amniotic fluid is going to leak out. And when amniotic fluid leaks out, the health of that fetus is going to be bad. And most of the time, the ONG, the OBGYN department is going to decide to expedite delivery. Then we have multiple gestation. This is because the twins kind of cause an increased distension of the uterine wall. And whenever the uterine undergoes a lot of distension at one point, it triggers labor, or it is a trigger for labor. Now, I have a whole playlist about obstetrics and gynecology where I talked about labor and things like that, how it begins. So we shall not go into that. Then we have the poor antenatal care. This is also an important thing because the risk factors are not going to be examined or found out early enough. If someone develops preeclampsia and it's not noticed, they come in with the seizures, which is eclampsia, then we are going to obviously expedite delivery because we missed out on a condition that could be prevented. Then we have fetal conditions like congenital anomalies, intrauterine growth restriction, and this one is because once you notice this fetus is having growth restriction, then you know something is wrong with the blood supply to that fetus. If you do not expedite delivery, then that baby could actually die inside. So it's one other cause that is going to lead to the birth occurring earlier than expected. Fetal distress is also an important thing. Then iatrogenically, doctors can go ahead and sometimes do things that cause the delivery, which could be good or bad, or in favor of the patient or not. So the core concept of prematurity is that the organs are immature. The systems are all going to be immature. But the key systems, we have the respiratory system, where we have surfactant, and surfactant is very important to prevent alveolar collapse. And when we have no surfactant, the alveolars are going to collapse on themselves. That's what gives us the condition respiratory distress syndrome. And we are going to have a separate video where we shall be able to dissect the ins and out of respiratory distress syndrome. We have the fragile germinomatrix. Now, the germinomatrix is a group of blood vessels that are found within the ventricles of the brain of the developing fetus. So at one point, those vessels disappear or they regress, but in a child, they are very, very prominent. And because these vessels are young, they are immature, the stress this baby undergoes actually leads to intraventricular hemorrhage. And this is going to be a very, very common cause of seizures and abnormal posturing, and then eventually death in these children. We have an immature gut, and that predisposes them to necrotizing enterocolitis. They're not ready to take in food. They're not ready to have their digestive system stressed. And then it is there having the stress, so it undergoes necrosis, and they develop necrotizing enterocolitis. They have an immature immune system, and that predisposes them to sepsis, and they have low fat. This is going to lead to poor thermoregulation and eventually hypothermia. So the first thing that is going to kill this neonate once it comes out of the mother is going to be hypothermia. If you do not have a radiant warmer or ways of keeping it warm, it is going to die of the coldness. So I want us to now look at the system-based complications, and these are very, very important for every doctor to understand. They're going to be tested on examinations as well as in the ward. The wards are going to test your knowledge. How well do you know these things? So we have the respiratory distress syndrome, which was also called the hyaline membrane disease. And this is because you lack surfactant. And when you lack surfactant, which is produced by the type 2 pneumocytes, whenever the baby is breathing, when they breathe out, the lungs are going to collapse on each other. Surfactant acts as a kind of lubricant. It maintains the surface tension there. And once you lack that, then breathing is going to stop very soon after that. We have the apnea of prematurity, and this is because the respiratory centers that are found in the medulla take a bit longer to mature. And in the preterm, it's very severe. The baby does not need to breathe at that age. The body is expecting that baby is still depending on extracted blood from the mother. But this is the baby who is outside, so they're going to have episodes of apnea where they're not going to breathe. And sometimes we go ahead and stimulate them with stimulants like caffeine citrate and things like that. We have bronchopulmonary dysplasia, and this is going to come mostly as a result of them being prolonged on oxygen. And we shall make a separate video where we shall cover bronchopulmonary discharge dysplasia also in great detail. We have pneumothorax. This is another cause that is going to lead to, and that is going to be faced by these children. When we look at the cardiovascular system, we have the patent ductus arteriosus. Now we have the ductus arteriosus that is going to get blood from the pulmonary system, blood that is supposed to go to the lungs in the fetus. It is going to bypass the lungs and go directly into the aorta. This is because the blood that is entering the heart of the fetus is oxygenated by the mother already. Now, when a baby is born early, this system has not yet stopped. The baby is not expecting that they need to actually oxygenate the blood with their own lungs. So the lungs are not going to get the blood in order to oxygenate it and send it to the rest of the body. But the blood is going to take a detour. It's going to take a shortcut. It's going to pass through the ductus arteriosus and enter into the aorta. And when it enters into the aorta, the baby is going to have blood that is deoxygenated, saturating around the body, and the cycle is going to continue until this fetus dies. So most of the time there is a rescue we do where we can give this baby prostaglandins, and when we give the baby we give him antiprostaglandins. These are drugs that prevent that lead to the closure of this ductus arteriosus, and we shall look at that shortly. So these babies have a low oxygen tension that produces a lot of prostaglandins, keeping the ductus arteriosus open. Then we have hypotension because the myocardium or the heart itself is not yet mature. When we look at the neurological part of it all, these babies are prone to intraventricular hemorrhage. And when you have the intraventricular hemorrhage, which I talked about being as a result of the germinal matrix vessels being fragile, we have things like periventricular leukomalacia. And I covered this in the video about cerebral palsy. This is when we have a bit of blood pouring around the periventricular region, and on the CT scan it's going to appear white. That's where the leukomalacia comes in. So when we have these injuries to the brain in the neonatal period, long term these babies go ahead and develop cerebral palsy, and sometimes they also have a developmental delays, and these come with very specific challenges. Now, infection is going to be also common. One, the immune system is immature. Two, we have IgG transfer in the third trimester. That is when the baby receives most of the IgG from the mother. This is the immunity that the mother already developed. So it transfers in the third trimester. But if a baby is born before the third trimester, then they're coming in fresh. No IgG. And this is going to lead to early onset sepsis, which is caused by ruby streptococcus, and then E. coli. And then the late onset sepsis, which can come in because they are staying in the NICU and then they catch a bug in the hospital, which is the nosocomial infection. Then we have the gastrointestinal complications, and that is mostly the necrotizing enterocolitis. This is because of ischemia and then bacterial translocation. This is due to feeding intolerance. Basically, it is not yet ready to receive food, but this baby has to eat. So they are going to receive food through the breast milk, and that is going to cause issues. They have a poor suck and swallow coordination too, and that is another issue because babies are already small as it is. Now imagine it's even smaller. It's a neonate, a baby less than 1 kilogram. This is less than 1,000 grams. This baby cannot have the poop in the mouth and then go ahead and swallow. So they have a poor swallow and suck thing. And this is going to be one of the reasons why they're going to stay in the NICU for a long time, because before this baby can have a coordinated suck and swallow, you don't want to really let them go back home. How will they feed? So hematologically, they have anemia of prematurity. This is because the kidneys are still young still. They can't produce enough erythropoietin. We don't have enough red blood cells, and that is going to lead to an anemia. We have hyperbilirubinemia because we have again the liver being immature. So the enzyme UDP gluconyl transferase that is supposed to conjugate the bilirubin is not produced in sufficient amount. So these babies are more prone to developing neonatal jaundice, and I have a video in the playlist for pediatrics about neonatal jaundice. Coagulopathy, again the liver is immature. It's not going to produce enough of these clotting factors, and so these babies are going to be prone to the bleeding. Ophthalmologic complications are going to be retinopathy of prematurity, and this is because these neonates are going to be on oxygen support for a long time, and the oxygen induces vascular proliferation. This is going to be in the retina, and once you have the vascular proliferation, this is going to cause issues with sight. These are babies who may go on to actually lose their sight, and to correct retinopathy of prematurity is something that is not easy. Sometimes it involves laser ablation of those vessels and things like that. Renal and metabolic complications, they're going to have fluid and electrolyte imbalance. The kidney is young. They're going to have hypoglycemia or hyperglycemia. Again, the body systems are all in shambles. Metabolic acidosis is also going to be something that is common. So the thermoregulation, They have a high surface area to volume ratio. The baby is a small creature, and they have decreased brown fat. And this brown fat is actually important to keep you warm. So when you have less brown fat, you are more prone to losing heat, and that is going to lead to hypothermia, which is going to worsen the morbidity in these children. So we have the immediate NICU management. When you get this baby, you want to make good use of the golden hour. That is the first minutes that you spend with this baby. You want to stabilize them. Make sure they're in a radiant warmer. And if they're less than 28 weeks, you're even required to use a plastic wrap to keep in as much heat as possible. The airway should be kept patent at all times, and use CPAP or ventilation. You need to give this baby CPAP. Remember, those lungs, the alveoli are going to collapse. And what CPAP does is that when the baby is exhaling, it's going to maintain the pressure within the alveoli. So the alveoli are not going to collapse. They're going to remain open for a while. So CPAP is going to be very important, or what we call positive pressure ventilation. Delayed cord clamping is important if that baby is stable, because remember, anemia of prematurity is real. So you need them to get every last drop of blood as much as possible. But milking of the cord is something that is highly discouraged, because if you milk this cord, you're going to cause a high surge in the blood pressure of the baby. And that high surge of the blood pressure is going to go ahead and lead to that baby having an intraventricular hemorrhage. So you need to monitor the SpO2, the blood gases, the glucose. You need access, and most of the time, the most easy way to get venous access is through the umbilical vein, arterial, or using the arterial catheter for the umbilical artery. These are going to be the easiest to find. Most of the time, these neonates are not easy to cannulate. So when we look at the other things that we have to consider, respiratory support strategy, CPAP is the first line. Always make sure you have CPAP, and then you can actually go ahead and intubate them and give mechanical ventilation if it's severe. Surfactant therapy is going to be life-saving, and there are very many forms of giving surfactant. Sometimes it's actually given through an endotracheal tube, so you need to intubate this child, and then the surfactant is poured into the lungs directly. It can be really life-saving for these children. Remember, they have the apnea of prematurity, so we give them a stimulant, and we rely on caffeine citrate for that. Nutrition, the preferred form of nutrition is breast milk, and breast milk is thought to be a bit protective to getting necrotizing enterocolitis compared to the other feeds, which are the formula feeds. And then you want to give parenteral nutrition if it's needed. That's going to be amino acids and lipids. And then you need fortification. Fortify the food for them if they are very low birth weight. Again, nutrition is going to be very, very critical in these children. Key medications that we use, we have the antibiotics like ampicillin and gentamicin. We have caffeine citrate for the apnea. We have indomethacin or ibuprofen. These are antiprostaglandins, and we know them. They are also painkillers, but they are NSAIDs. What they do is that they block the prostaglandins. When they block the prostaglandins, the patent ductus arteriosus that was being kept open by the prostaglandins is going to close. Then vitamin K is going to prevent the bleeding, and iron supplementation may actually help improve on the anemia. Then we have the fluid and electrolytes. Now, these kids are going to lose very many electrolytes and water because the kidneys concentrating ability is not yet grown at this stage. And you will notice that they are going to receive a bit more fluid compared to the normal neonates. So on day one, they're going to receive about 60 to 80 mils per kg per day, while the normal neonate may receive about 40 mils per kg per day. And you're going to increase this almost by 20 to 40 mils accordingly, depending. You want to keep a urine output always that is about 1 mil per kg per hour. So you're going to make sure you're giving a bit more fluids. But remember, babies also don't tolerate the fluids very well. And these are kids who are very prone to electrolyte changes. You have to make sure you're monitoring the sodium. You have to make sure you're monitoring the potassium at all times. And then the weight changes in this child. Fluids are going to be very tricky. Everything has to be charted Everything has to be well followed up with. Otherwise, you're going to give less fluid or you're going to give a lot of fluid, and both situations are fatal to this neonate, this preterm neonate. So there is developmental care. We want to give this baby minimal handling. This is a baby who is prone to intraventricular hemorrhage. This is a baby who is very tiny. You don't want them to be carried around a lot. Let them stay in the radiant warmer. Let them stay in one safe, cool place. Reduce the noise, reduce the light. Do not overstimulate them. Kangaroo mother care can be important to keep them warm, and the position, they should be in a flex position. So conditions for discharge. These are very important to understand because you don't want to keep this neonate longer than you should. They will fall sick while in the NICU, as well as you don't want to release them early because if they go home and they get a complication, then they might easily die. So some of the conditions for discharge is that the breathing, the baby should be able to breathe normally on room air. There should be no apnea and there should be no bradycardia for at least 5 to 7 days. Then the temperature should be now stable. This baby should be able to keep a stable temperature. And in an open cot, they should have a temperature of about 36.5 to 37.5. When it comes to feeding, they should be able to feed fully orally. You can't send a baby home when they're on TPN, total parenteral nutrition, of course. They should be able to feed well. And some people even, in fact, this is the best practice, consider to only discharge if they have a good suck and swallow coordination. Then, consistent weight gain is something that is important. The growth should be a steady weight gain, usually of 1.6 to 2 kgs, but it's not mandatory. And then medical stability. There should be no active illness. Don't send them home on meds. They should be off IV meds. They should be off oxygen and off CPAP. And the caregiver should be ready. They can feed the baby. They can keep them warm, as well as identify any danger signs. And almost in every video I've made, I talk about the danger signs. Children. Then before discharge, make sure these babies are immunized, and then follow up on that. And then you have to monitor the growth and development of these children. So we have come to the end of this video, and I'm glad that we have talked about the preterm baby. We are going to continue with our NICU series, where we are going to be covering every other topic, everything that is important in newborn care. My name is Benjamin, and this is Med One Pager. And if this is your first time around and you have stuck to the end, then I hope you have subscribed, or you're going to subscribe to the channel, because I would love to continue seeing you here. I would love for you to continue getting notifications whenever I post a new video, and we shall meet in the next video. Don't forget to leave a like, ask me anything in the comment. I'll be there to talk. Follow me on Instagram or DM me under Med One Pager. May God bless you.